would you like to improve your health and keep your family safe? You're listening to the Healthy Home Hacks podcast, where we firmly believe enjoying optimal health shouldn't be a luxury. Healthy Home Authorities and husband and wife team Ron and Lisa will help you create a home environment that will level up your health. It's time to hear from the experts. Listen in on honest conversations and gain the best tips and advice. If you're ready to dive in and improve your well-being and increase your energy, you're in the right place. All right, here are your hosts, bowel biologists, authors, media darlings, vicarious vegans, and avocado aficionados, Ron and Lisa Barris.
Are you experiencing embarrassing gas, bloating, constipation, or other digestive woes? Well, you're not alone. Did you know 70% of Americans are dealing with digestive issues right now? And guys, it's getting worse. Inflammatory bowel diseases have jumped 50% in just 2 decades. Something isn't right. The gut-brain connection alone affects 1 in 5 adults. How would you like to improve digestive wellness and overall gut health in just 12 weeks? Grab our must-have resources for busy people. Head over to ronandlisa.info/gut. That's ronandlisa.info/gut. You're welcome.
Hello, everyone, and welcome back to the Healthy Home Hacks Show. I'm Ron.
And I'm Lisa. And today we need you to stop what you're doing and listen, because this episode could literally save your life.
We're talking about breast implant illness, BII. An estimated 400,000 women believe their implants are making them sick. Tens of thousands of adverse reports have been filed with the FDA, and with roughly 300,000 implant procedures performed every year in the US, this is a public health conversation we can no longer ignore.
That's right. And women are reporting fatigue, brain fog, joint pain, hair loss, and autoimmune-like symptoms, often dismissed by doctors for years. The research is ongoing, but the FDA has added new warnings, and the conversation around patient safety and informed consent is finally gaining real traction.
If something in your body doesn't feel right, you deserve answers, and you deserve to be believed. This episode is for every woman who has implants, loves someone that does, or is thinking about getting them. Stay with us, and let's get into it.
Our guest today, Sean Doherty, MD, FACS, is a board-certified plastic surgeon in Boston, my hometown. Dr. Doherty is seeing an increasing number in patients seeking guidance on BII, including those considering implant removal, which you may have heard of as explants or replacement. He emphasizes the importance of individualized evaluation, realistic expectations, and evidence-based discussions about the risks, the benefits, and the surgical options.
Welcome to the show, Dr. Doherty. Yes.
Thank you. Thank you so much for having me. I appreciate it.
Good job.
We have a crowd. We have an audience who's excited to have you. Oh my gosh, we're so excited for you to be here. This is such a hot topic right now. You can't go on social media or the internet without an article about this. So everyone's becoming aware. And I just feel like this is so important to cover. And I know our listeners are going to love today's show. So I want to start for listeners who may be unfamiliar. How do you define breast implant illness? And what has contributed to the growing awareness around it in recent years?
Well, that first question is actually challenging. So breast implant illness is a constellation of symptoms that are unfortunately associated with so many other things, but a group of symptoms that are likely related to a patient having a breast implant in their body. And so that is kind of how we present this. The challenge with this is that all of these symptoms, which you very appropriately listed earlier, can be associated with so many other things. And where we're at is that science has not given us a test to determine, validate, diagnose breast implant illness. And so we as physicians need to listen to our patients. Our patients need to talk to us, be honest with symptoms, and come up with this diagnosis, because diagnosis is called a diagnosis of exclusion, where we exclude everything else that may actually be causing these symptoms. And when everything else is ruled out, we determine, okay, likely potential that the implant could be the cause of this. In a sense, see it as your body's reaction to a foreign body in itself.
Well, sure. It's like a splinter in your finger, right? It wants to reject it sometimes, hopefully.
I do want to start the conversation off with, though, that implants are a huge part of my practice. I perform a lot of augmentation procedures. They are FDA-approved devices with a lot of safety and science behind them. So let's start with that. But they are medical devices. And I think that's what I speak to every person who's considering this procedure, considering having implants in their body, say, a medical device. They are inherently not perfect, and they're not perfect for several reasons. They can rupture, they need to be monitored, and they can create a reaction in your body. And it could be a localized reaction, something called a capsular contracture, or a more systemic reaction, which we're discussing today, which is breast implant illness.
And that list of symptoms is like, we just did a mold episode, and it's very similar, actually, a lot of those symptoms. I mean, it's really hard to, like you said, to fine tune and say, is it coming from this? Is it coming from that? And a lot of people are getting treated for the specific symptoms, right? And then the body's still, producing them if you don't get to what the root is. So I have a question, because I'm not a breast, pun intended. I haven't had breast implants personally, but so is it mostly saline, or are they still doing silicone, or both? What is the traditional breast implant today?
So in this country, both saline and silicone gel implants are available and FDA approved. I would say a majority of my patients currently request silicone gel implants by about, say, 90%.
Really? Okay, I'm surprised about that.
Yes. There's a cohort of women in the early 2000s that the only implants that were available for them were saline implants.
Okay. Yeah, because they banned the silicone for a while.
Because there was a concern for reaction in the body. Production of them was halted. People were not having them placed. They underwent significant studies and then came back stating that there is actually no direct causation to autoimmune disease. And having said that, there are still documented cases of reactions to implants. And so your question about what type of implants, every implant has been associated with patients who have been diagnosed with what we call breast implant illness. So there is not one specific implant that is, say, safer than another. Because if so, we as physicians, we're doctors, we would recommend the safer implant, right? So it is because it's theorized that it's a reaction to the outer lining of the implant, not much what's inside. And a saline implant and a silicone gel implant, the outer lining is the exact same. And so the reactions are the same. So that's
see. But it was the leakage, wasn't it? If the silicone were to leak.
No, it's not. Breast implant illness has been associated with intact saline and silicone as well as ruptured. So there is not an
interesting
risk
okay.
of that. That would make kind of it easier for us to say that people have rupture or more risk for that, but that is not the case.
No, I have an odd question. So can you not do sports if you have breast implants? Is that something that you shouldn't do? Because
you most certainly can. You most certainly can.
I was going to say.
I know. I wondered about that.
Meaning, are you talking about significant impact of sports in
or like even basketball or field hockey or something like that? Would that be a sport you wouldn't recommend?
There are a lot of women out there who have successful breast augmentation and are quite active in sports activities. Certainly aggressive pressure onto the chest, say like boxing, kickboxing, puts them at risk, but no, we really try not to limit people's activities after a surgical procedure.
Okay. So we did a podcast, episode 130, just recently on the MTHFR gene, which I'm guessing you're familiar with. And that show's really interesting because it does talk about, like, maybe with some of these women, their body isn't detoxing appropriately and they don't have the down cycle, systems to detox that stuff out, why it would explain in some ways why some women don't have any issues and some women do.
And I think we're very much in the infancy of determining that. And I just caution listeners to kind of jump on something like that when there isn't kind of scientific evidence to prove a causality or a risk, because that is absolutely what we as physicians are looking for. And so it's a big part of our community to help to understand this, determine if we can figure out if a patient is at more at risk for this or not. But there have not been any determination of anything statistically proven to put someone more at risk. We thought initially back at the beginning, patients who have tattoos, patients who are smokers, patients who have had particular surgery before, take a particular medicine, there's absolutely no cause and effect that is statistically evident.
Interesting with the tattoos. I have heard that ink is very toxic and it can lodge in the lymph nodes. Is that true?
In so poorly done and so aggressive tattoos that or have complications, but fortunately or unfortunately, there has not been a causal relation noted.
Are there any studies done on people who have not replaced their implants on a regular basis or when they should? For example,
To be more at risk for breast implant illness? No.
Yes. Oh,
But
okay.
I will take this opportunity to remind patients that implants are not thought to be lifetime devices because they can rupture and ultimately create a reaction in your body. So it is recommended that implants, both saline and silicone, get exchanged roughly between 12 to 15 years. That's the overall recommendation initiated by the FDA and then also supported by most plastic surgeons.
Okay. And I don't think a lot of women are doing that. I know some women that have not done
So
that.
I agree. It is a recommendation. And then
Right.
also because implants can rupture, which is what we don't want in one's body because it can actually initiate more of a reaction, put more at risk for capsular tightening, we like monitoring implants. So if a saline implant ruptures, oddly, right away because there's a deflation of size and that your body absorbs that saline. It's very safe. Saline is very similar to what fluid is injected during surgery. Your body absorbs that and then it needs to be exchanged. We call that a social emergency. If a silicone gel implant ruptures, it's very hard to tell clinically because the gel is like squeezing a gummy bear, squeezing a Jell-O mold.
Interesting.
Holds its shape unless there's continuous pressure on it. It loses its ultimate shape. And so we want to stay ahead of that. And so studies have shown that at 5 years, you're at more risk than baseline to have an unknown rupture. So an undetected rupture. So FDA recommends that patients get an ultrasound or an MRI at that point to determine if there's any irregularity. And if there is, it's recommended your implants get exchanged. Repeat that every 2 to 3 years until about that 12th to 15th year, that then it's recommended that implants get exchanged. And it's for patients who are considering this procedure that ultrasound or that mammogram may come at their own expense because insurance may not cover that. And
I'm sure that would be out of pocket.
likely why
That's a cosmetic procedure, right?
Some cases it is appropriate given someone's medical history, risk of breast cancer, so they can have more a close observation and evaluation of their breast, but that's not everyone.
And is it true that it's harder to detect breast cancer with breast implants?
No, I would say no. If there is a complication with a breast procedure, say the capsule is the rind of tissue that forms around an implant, extraordinarily normal. It's supportive and helpful for the breast. That can get hard. And so that's what capsular contracture is. And that's when a breast looks quite deformed, irregular, hard, and it can ultimately hurt. And that's how we grade capsular contracture. And then that can make it challenging to evaluate either mammogram or ultrasound. And so then MRI is typically required to evaluate breasts. But I wouldn't want any of your listeners to think that having breast surgery with an implant that is done well and has been healed well has any correlation with breast cancer or any correlation with challenges with evaluating their breast tissue or make it so they shouldn't have mammograms because they absolutely should. They should absolutely monitor their tissue for breast cancer, which typically starts at age 40 for patients who don't have significant risk factors in their family. And that usually begins with a mammogram.
Yeah. Well, there's so many new cutting edge screening devices coming out
and I
that
think
are non-invasive, which I'm a proponent of. I personally like the thermography, but there's a new, I think it's called the QT scan or something like that. It's a new.
And I have some patients that have their bodies monitored by that. And I listen to that. We're still not there with defined science though, in long-term studies. And so I like to be thinking out of the box. I like to have other people's thoughts and opinions. And so I'm not so narrow-minded that I'm not open to things, but I think we should admit that we do need science and we do need proven strategies to keep people safe. But I think a multimodality way of doing that is currently appropriate and probably in the future will be more robust. So I look forward to that time.
Well, Dr. Doherty, as a board-certified plastic surgeon, what are the most common symptoms you're hearing from patients who are concerned about BII?
And I think it follows with kind of the national trend. So joint pain, muscle pain, and brain fog. I think the symptoms that I would say most people who kind of fall into this category initially report. And so for a woman, say in their 50s or 60s, or say 50s, that is reporting that, I think the initial thought is, okay, you're going beginnings of menopause. Those are symptoms associated with menopause. So that may be true, but it's not fair to just say, no, you blame this on menopause and this is where we're at. I think it requires that a patient be very advocate for themselves, kind of be constant in their discussion, be forthright and be open to conversations with multiple doctors and get a doctor in medical professional that you speak with that listens to you. And that may take a couple of more people, but that's ultimately what you want, because that's what we need to do as practitioners, is to listen to our patients. And I think historically, patients who fall in this category of being concerned about breast implant illness or have it traditionally feel dismissed, traditionally feel not listened to, kind of pushed aside because your breasts look fine. What's the problem? That is just not what we want to do. It's not what I want to do, and it's not what most of my colleagues want to do. But everyone at the table needs to admit it is a very challenging clinical situation to be in. When we can't do a test to determine if someone has something, it's challenging. So when a patient and a physician can admit that and work together, it can be a much more successful journey.
Yeah, I think that being comfortable with the surgeon you choose, not feeling intimidated to be able to have those conversations and ask those questions, because no matter how great their reputation is, you don't want to feel like you can't speak up for,
Correct.
and be
Correct.
your health advocate.
Correct.
I remember years ago, there was textured breast implants that got
Yes.
pulled. Those never came back to the market.
No, there are still textured implants, and the reason why the textured implants were having issues is an association with a cancer, so a lymphoma. It's called ALCL, and it is also due to an interaction of the capsule, which again is a tissue that forms around an implant, creating an interaction with a textured implant. So it's almost like a Velcro interaction or a cobblestone interaction. And so, to simplify those nooks and crannies, it is theorized has created a biochemical scenario where a lymphoma could happen. And also, a squamous cell carcinoma has been found in women who've had breast implant illness. So, that is the reason why those textured implants, specifically a specific model through Allergan, were taken off the shelves. And in the United States, we tend to use more smooth implants in general. It tends to be just nationally what we do. And those are less associated with the ALCL lymphoma. But that is very different than breast implant illness. Those are two different things.
Okay. So when patients come to you concerned about possible breast implant illness, what does the evaluation process look like for you from your first conversation through deciding the next steps?
So listening to a patient, I like to just hear why they think they have that, what are their symptoms, how long they've had those, and what else is going on with them medically. Do they have autoimmune issues? Do they have thyroid issues? Have they ever been treated for Lyme's disease? In the Northeast, that is a big thing to be concerned about as well. Are they very reactive patients? Do they have problems with vaccines, viruses? Lots of food allergies, medicine allergies? Are they kind of what we call a reactive person? And that's not a judgment statement at all, but it's just kind of a fact-finding thing. Then I want to know what they've done so far to evaluate themselves. Have they ruled out autoimmune issues? Have they ruled out thyroid issues? And how was their surgery? Were there complications with their surgery? Are there issues? Are there physical problems, discomfort, capsular contracture, hardness of that? That is what I want to know. Have they had their breasts evaluated with a mammogram, ultrasound, or MRI?
Interesting. Are there certain risk factors or patient profiles that make someone more susceptible to complications or symptoms associated with implants?
Well, I mean, that's the ultimate question, and there is not. And that is what a lot of our studies have shown, and which makes it extremely challenging to protect. It's very hard for a patient, and I love when patients come in and say, can we talk about breast implant illness before surgery? I say, fantastic, let's talk about this, but let's keep it in perspective and talk about real numbers and actual risk. And I can't tell someone that they're in theory more at risk than others. From just a simplified point of view, if I feel like someone has autoimmune issues, if they are what I say of a very reactive person, we may have a more significant discussion on the pros and cons of this procedure. Is this a risk that we should take? And are they willing to handle kind of the negatives and actually handle breast implant illness? And if not, which I fully respect, are there other ways to achieve a breast surgery?
Like a breast lift? Do you get a good result from a breast lift compared to, because that's not putting anything foreign in, right? That's just a surgery.
So those are two, well, they can be combined, but they're two different surgeries. A breast implant would be to augment the volume of the breast, so increases. A breast lift, which would be because of, say, we call sag of your breast or laxity of breast tissue. So one could lift one's breast, get a better shape of it. So in theory, put the nipple back on the center of the chest, kind of where it's supposed to be.
Well, they don't remove the nipple, right? You're just moving up. Yeah, Ron's freaking out over
there. Stays in place, and we tailor tack, bring the skin together and the underlying tissue to lift that up. And that can be very successful for patients. Just give a nicer shape to the breast, feel better about it. And in some cases, their breast is too big for a patient and then they want that reduced in size. And that's a really nice way of doing that. But then there are some women, especially who've had multiple children and feel their breasts are deflated.
Yes, after breastfeeding. That's a big issue.
So there's a sag and also decreased size of breast. So we often combine implants with a lift. And that can also be a very successful procedure, but a lot to talk about and a lot of surgical planning. But to backtrack, another way of volumizing the breast would be fat grafting. So that's taking fat from your body, so by way of liposuction, and then injecting it into the breast. Everyone sort of said, yeah, I'll jump on board for that.
Is that usually from the stomach or the butt? Where does that come from?
I like to take it from the abdomen and the flanks. Places are upper extremities or lower extremities. We try not taking fat away from the buttock area. The buttock doesn't do very as well with taking away fat, and most people actually want to add fat to the buttock to create more of shape. But it can be a very successful, safe way.
Everybody wants fat taken from their abdomen, so that seems like a no-brainer.
However, a good surgeon will talk to you about it could actually create a negative. That if you're taking fat away, it could create laxity of skin, looseness of skin. And there are unfortunately many women who want to be in the category of getting breast augmentation with fat, but they don't have a lot of fat on their body. They're just lean patients. And you have to have the fat for it to be.
Oh, is it a lot of fat? Like that?
Yeah, we do.
It's a good amount. Okay. I thought it would be a tiny amount.
Kind of, your body can not have all the fat take. We say we almost kind of overfill because not all of the fat takes. I say fat grafting is like planting seeds. You kind of overplant seeds. You don't think all of them will take. And then sometimes you need to go back and do reseeding and add a little bit more fat. It's not the right pathway for everyone, but it can be a very nice way of improving volume of the breast without having the negatives of the implants, which we said.
Is that still a dangerous surgery, or is that kind of outpatient, the fat grafting?
Yes, that can be an outpatient procedure. Fat grafting is a very old standard tool for plastic surgeons. Taking something from somewhere and bringing it elsewhere. Fat is lovely. It increases blood supply to the skin. It encourages improvement of skin quality, and it's just a natural way to improve size and shape of one's body.
Yeah. So because I like the natural alternatives. Obviously, that's our whole mission here. So that's why I'm kind of asking those for people who are on the fence that are like, what could I do? If they're
absolutely,
yeah, the lift.
Mm-hmm. Yeah. Yep. And so fat grafting can also be added to a breast lift. And it's a really nice way if you're lifting up the breast, but a patient is looking for a little bit more what we call upper pole fullness, putting up there can be hugely successful.
And it wouldn't be lumpy, or is that a risk too?
So it is a risk, and that is the goal is to place fat in a very, we say like a crosshatch pattern, thinly in little bits everywhere. We don't dump fat into one little area. It's sort of like painting or spreading things. And so there's the style of fat grafting is certainly associated with better outcomes, but it is a very nice, standard, safe plastic surgery procedure.
Oh, okay. Okay. Interesting. I'm learning a lot. So for patients who believe they may be experiencing BII, what options are available to them? And how do you guide decisions around implant removal, called explants? A lot of people have heard of that term, or replacement, whether they're choosing one or the other.
So so if someone gets what we call diagnosed with breast implant illness, in my opinion, my recommendation is to remove the implants. And it is thought that someone who's diagnosed with breast implant illness, their implants are removed, 85% of them feel better.
Yeah. I've been reading a lot about that too. It's like
Improvement of
instant, right?
symptoms by 85%, which means that 15% of those patients, then those symptoms were not associated with their implants. It's not a small number, but it is, I mean, that's not zero, but it is not everything. So there is an indication to remove their implants. But then your thought of putting implants back in, well, I say to patients, if we're thinking that the implant has caused a problem, we took the implant out and you are feeling better, it would not necessarily be my recommendation as a physician to replace an implant.
I think I can't imagine going through all that nightmare as a woman and then getting them out and feeling, oh my God, it feels so much better. Oh, let me go back and put them in again. That just feels counterintuitive. But
True, but I think some people just have a very different thought process, and that's where as physicians come up with other options. So maybe lifting the breast, making it smaller, but having a better shape. Maybe this is where we talk about fat grafting. We're not going to get as robust of a size of a breast, but maybe we can get something and keep you natural and stay away from the implants because we've decided that they're not ideal for that patient.
what percentage of patients would you say are coming in because they want really large breasts versus the percentage of patients that just feel insecure and just want a little boost? Is it all across the board?
Yes. I think to answer that question, we have to think about geography, though. I'm from Boston.
California, we already know the answer to that.
Yeah.
That's where we are.
Right.
We're in Newport Beach, Dr. Doherty.
Right. So the aesthetic is a little bit different in geographical areas. In Boston, my patients tend to be fairly conservative, and they're not really looking for an outlandish outcome. The term yoga breast or ballerina breast is really kind of topic now, and people are referring to that. That's just a very subtle volumization that probably is imperceivable to someone else, but someone just feels better in their clothes. And that result could be achieved with a small implant, but also with fat grafting. In my practice, I would say patients tend to ask for more of a conservative outcome as an aggressive outcome.
Because I think there was a trend for really large breasts like years ago. And then it kind of flipped, right? I mean, this happens with everything, right? Eyebrows go thinner and thicker.
Yeah, and filler and lips. And, and now for much less of that as well. And I'm seeing a parallel with breasts as well.
With breast. And so your breast material, is it collagen? By boosting collagen, would that increase your breast at all? Or is that?
So that is helpful for skin and soft tissue. Your breast is composed of fat, glandular, so breast tissue, and then kind of connective tissue that holds it all together. There's not a reliable way of increasing breast tissue except for fat grafting.
It's not going to just grow. When it's done, it's done. Correct. Yeah. I remember seeing some herbal capsule years ago. They were advertising it, and they're like, this will increase your breast. And I'm thinking, I don't think so.
I mean, getting pregnant certainly will increase one's breast. I don't know if that's really the reason to do that, but that is typically a side effect of being pregnant. Whether you breastfeed or not, your breasts get larger, engorge, your breast tissue becomes more robust in order for you to be able to breastfeed, which not every woman does or can or wants to do.
But isn't that that's because of hormones, right? Is that why that happens?
Correct.
So if you had hormone therapy, theoretically, wouldn't that do it too, or no?
So that's not a great way of thinking about that because you're increasing hormone intake to traditionally grow breast tissue is just not where
You're
we're
going to
at.
whack your hormones, all the
Correct.
rest of it.
Well, I
Yeah.
was just curious. Yeah, this one.
Yeah. And
breast-
also with the estrogen positive breast cancer.
Oh.
Yeah. You definitely
Good
don't want to
point.
be adding more estrogen. Yeah. Yeah.
For sure. So how has the field of plastic surgery evolved in recent years to better prioritize patient safety, informed consent, and long-term outcomes when it comes to breast implants? And I heard recently about a safer implant called Motiva. Can you shed light on this? And is it all it's cracked up to be?
So first part of that question, what can we do to make things better? Well, listen to patients, have kind of transparent discussions with patients, listening to them, ask what their concerns are, tell them what our concerns are, and be very open, ears open, eyes open about risks and benefits of a procedure before one starts. We're letting them know that a breast procedure is not kind of a one and done. It requires maintenance and monitoring, and it doesn't need to overtake your life, but you need to be thoughtful of this. And your tissue can be changed, affected down the road. So someone that has a breast augmentation procedure, say in their early 20s, their breasts are going to be different, say in their 40s or 50s, maybe after they've had children, weight gain or weight loss. And then there likely is going to be a recommendation to change your breasts based on your aesthetic desires. None of that has to be done. And then I think we can keep people safe by continuing to do good science, doing studies that are scientifically rigorous and provide appropriate data so we can give our best information to patients that is not wholly emotionally based. But we are physicians, we have emotions, we think about that way, but we should make decisions based on science and data. So providing more of that.
Open dialogue, like you said earlier.
Is there a limit to the number of procedures you can do? So, for example, if someone got breast implants at age 20, 30s, 40s, 50s, 60s, is there, after the fourth time, do you have to stop? Is there any studies on that?
There's not a standard to that, but we don't, I love to do surgery, but we have to be respectful of tissue. And so as a plastic surgeon, I put tissue to its limits. And so we know that sometimes we've pushed tissue to its limit. So women who requesting larger and larger implants, stretching tissue, someone has to have an honest discussion with them and saying, what are we doing here?
Right. That's really important.
A problem going down the future, and how are we going to fix that problem? And a good surgeon, I think, has those honest discussions. But there's not a limit to that as long as it's safe, as long as a patient understands what they're getting, what they're not getting, and they have an honest discussion with their doctor. I think appropriate procedures can be provided.
Is that incision always the same? So every time, does it go through the belly button?
No, we tend to not do, those are called transumbilical breast augmentation. That has, I think, had its time. We tend to not. The three ways of placing an implant are through an inframammary fold incision, which is the inframammary fold underneath your breast, around the areola, that's called a periareolar incision, or through the axilla. My preference is the inframammary fold incision. It's closer to where we want to be. We keep people safe. And to be honest, I feel that there's an increased risk of capsular contracture, meaning the tissue getting hard when the implant is placed through a periareolar incision. That's a little bit of a controversial statement that I'm making, but I feel that way. And so we stay away from the breast tissue. From a breast augmentation, we leave your nipple and areola intact. We maintain sensation. We maintain ability to breastfeed later. It's just a preference. And I do not perform a transaxillary breast augmentation. I think that is a challenging procedure that has a significant risk of revision and is just not my favorite way of doing it.
Yeah. And I meant to ask you this earlier, is an explant surgery a lot less expensive than an implant, or are they equivalent?
So that depends. It depends on what needs to be done. So explant just means removing the implant. And so there are some patients that an implant can be removed under local anesthesia. So numb the incision and remove that. It's not always for everyone. It's not always my recommendation, but that will just remove the implant. However, a good surgeon is going to help someone predict what their tissue is going to look like when their breast implant is removed. If the breast implant has been there for 15 to 20 years and they've had multiple children, they've been weight gain, weight loss, their tissue is not going to be the same as it was when the implant was placed, and one needs to help predict what that is. So They may need a lift if they're trying to get a better shape of their breasts. They may need an implant placed back in because they missed some of that volume, or fat grafting may be part of that. So that is an extremely case by case basis. And you just want to have an honest discussion with your surgeon saying, what do we think are my best options here? And how do you predict this goes?
Have you come across examples of patients who have had breast augmentation that wasn't replaced for 30 or more years? Has that ever? Okay.
That didn't have any issues? Is that possible?
Yes, it has. It has. And there are some surgeons, this is not my thought, but if it's not broken, don't fix it. I'm a little more conservative. I like a little bit more evaluation, but there's nothing wrong with them. Great. That is excellent. I have seen women come with implants that have been there for 25 to 30 years, that they're ruptured and have created not a medical problem, but a very challenging sort of scar tissue problem to removing that implant and removing the following tissue. And then it creates kind of an aesthetic problem as opposed to a medical problem.
Yeah, they don't want to, it's a surgery, and every surgery has risks, right? Even a simple surgery has risks. So to answer the second part of Ron's question, I heard about this Motiva implant. Can you tell us a little bit about it? Is it?
Of course. So the Motiva implants are the newest implants that are available to us as U.S. surgeons. They're FDA approved. They are silicone gel implants, and they're called nanotexture or microtexture. If you feel them, they actually feel quite smooth. There's a very limited roughness to the edge, and that creates a nice stable interaction to the surrounding tissue. So that capsule becomes supportive and moderately thick. They are FDA approved, much like the other implants that are here in this country, and they're newer. There's less time with these implants in our country. However, Motiva has been used in other parts of the world for quite some time, so there's a lot of science behind them. I personally don't use Motiva implants yet. There's not a reason why I haven't. It's just I like to be kind of last to the party.
Yes, I do too.
I'm interested in them, and as more patients ask me about them, I'm more interested in using them. I don't know that they're going to be particularly better, but they're another option. And with the one thing I can say is that Motiva implants there's no documentation that they've been associated with that lymphoma that I spoke about, that LCL. And that
because the person that the reason I heard about these is she's a big influencer. I won't say her name. She had breast implant illness. She got her implants removed. She is very flat chested, like very. And so she just didn't like how she looked. So she waited like a year or however long. And then her doctor told her the Motiva was designed for people with autoimmune diseases. And I thought, okay, I don't know about that.
Yeah, to me, I don't have any knowledge of that. And we spoke about that scenario earlier, that the implants are out for a reason of concern with breast implant illness, and then the desire to put them back in. That's a risk. That's a leap of faith. And that's a challenging situation to be in. I'm not sure that I would recommend that to someone.
Yeah. And why would they say they're safer when they're really?
Correct.
Yeah, okay.
Foreign body, they still can create a reaction in there, even though our modern implants are less reactive than, say, even implants from 10 years ago, which is why numbers are going down from these negative things, but they're still there. And that's a statement that I'm not sure I would make at this point.
Yeah. Okay. Perfect. Well, this was great. I've learned so much. I really didn't know anything about this world except the illness part, because is there anything you want to leave listeners with? Any last little tidbit or?
Well, I think that if anyone is interested in doing surgery on their breasts, I love the internet. I love social media. I love that for information. Gather your information, but go see a board certified plastic surgeon.
Yes. Imagine not going to a board certified. Like
you want someone touching you want someone examining you. You want someone who can really listen to you, read you, hear your emotions, see where you're at, if surgery is right for you or not right for you, and give the best and safest options. We love technology. We love implants. They're not always right for everyone, and they have risks, and we should admit all of that. But they could be very good, safe, and helpful for some people. So just be open.
So don't get the Groupon breast augmentation.
I was wondering about that. The Groupon, like for eye surgery, for example.
From the clinic that just opened down the street, guys, ladies.
Please don't do that. Please don't do that.
Now, you only work in Boston, right? Just Boston?
That is correct. In the Boston area.
Okay. Are there plans to expand? Are you going to be on the West Coast now?
there are a lot of, all my Boston patients deserve good plastic surgery.
Yes,
so
we got enough plastic surgeons. Rodeo Drive.
I don't think they're asking for any new plastic surgeons.
That's right. No shortage in LA.
Right.
Well, thank you so much for being with us today, Dr.
You're so
Doherty.
welcome.
Yes.
Yeah, this was great. You can learn more about his services at Sean, SEAN Doherty. That's DOHERTYMD.com.
And as always, friends, you can find the links in the show notes at healthyhomehacks.com. We appreciate you. Be sure to leave a review, a rating. 5 stars are always, always appreciated. And if you're not already subscribed, consider this your whisper. Yes. Thank you so much. Thank you. Thank you, Dr. Doherty.
Bye. Thank you, Dr. Doherty.
Thank you.
This episode of the Healthy Home Hacks podcast has ended, but be sure to subscribe for more healthy living strategies and tactics to help you create the healthy home you've always dreamed of. And don't forget to rate and review so we can continue to bring you the best content. See you on the next episode.